Let's Cover That podcast is brought to you by CM&F Group, professional liability services for over 200 healthcare professions. Visit our website at cmfgroup.com/podcast for more info.
Good morning. Thanks for being here. So we're going to spend a few minutes this morning talking, well, actually the title of the presentation is Learning from Experience, real world examples of malpractice claims. And we're going to talk shortly about malpractice, but then there's two cases that I want to present to you, real cases in terms of PAs who were involved in malpractice cases. All right, thank you. So first of all, let's be clear what malpractice is. Basically, malpractice is negligence. It's when a clinician is found guilty of negligence, something that went wrong. And, the interesting thing about negligence and about malpractice for PAs is if you would ask me 50 years ago if PAs were sued, and people would scratch their head and say, I don't know any PAs who were sued. But now we do know that PAs are involved in malpractice suits. And why is that? Because there are now a lot of us. People know who we are, particularly attorneys, and we're playing a major component in healthcare. And so what happens is, PAs do get involved in malpractice cases. So really, when we talk about negligence, we're talking about a PA that doesn't measure up to the standard of care. If the malpractice caused harm, a lawsuit, may be filed to recover damages for the harm that was suffered. Okay. The Healthcare Quality Improvement Act passed back in 1986 requires that all malpractice payments, in other words, losses, payment that occur from the insurance company, it has to be reported to the National Practitioner Database. And that goes there permanently, and it's for any kind of payment that occurs. If you look at some of the recent research in terms of claims, you can look here, if you looked at 54,772 claims, you can see that PAs were defendants without APRNs or nurse practitioners or physicians in about 26 of those claims. So let me repeat that. That means there are 26 claims where PAs were named without a physician. Nurse practitioners were defendants without PAs or physicians in 63 cases, and not surprisingly, physicians were defendants without PAs or NPs in 37,354 cases. So about 75 of claims naming advanced practice providers co-named physicians. So more claims naming PAs and RN nurse practitioners were paid on behalf of the hospital in practice, 38 and 32% respectively compared with physician claims there. Payments were less likely for inpatient care. You can see the data there. And a really important thing that I want you to take away from this today is claims against PAs usually fall into about 4 areas. Number one, lack of adequate supervision. That tends to be the most common one. Untimely referral, failure to diagnose, and the other one is inadequate examination. So those are usually the 4 components where PAs are sued for malpractice. So what is negligence? To win a negligence case and recover damages from a PA, a patient has to prove each of these 3 elements. So they have to prove that the PA owed the patient a duty of care. Well, that's pretty common. Somebody walks into the office or comes up to the emergency room, or as a patient in surgery, the PA that's involved in that does have a duty, to care. Then they have to prove that the PA breached that duty. We'll talk about how that occurs in a minute. And if it was breached, then the patient was harmed as a result of the PA's action or failure to act. So the plaintiff's attorney has to prove all 3 of these things to prove a negligence case. Okay, once that occurs and that's proven, then they have to determine, the 4th element, which if there was a duty, if there was a breach of standard of care, and what was the proximate cause, and if that's the case, then the PA would be liable for that malpractice. Okay, we're going to talk about a couple of cases now. So let me go through this real quickly. So this is a 76-year-old female who came to a dermatology practice complaining of an unexplained pink, scaly, and itchy rash on her arms, palms, and legs. She was a resident of an extended living center, had been seen a week earlier by her primary care physician for an itchy rash on her torso, and she was placed on over-the-counter Benadryl. She was also placed on fluconazole for what the provider called oral thrush on the same date. So when the rash did not improve and actually got worse, the RN at the extended living center suggested a referral to the dermatologist. So the patient was seen the next day. History revealed hypertension, hypercholesterolemia, and the patient was a former smoker. So the patient was seen by both the PA and the dermatologist in the dermatology practice. The patient stated that the rash had started a week earlier, was getting worse, had now moved to her hands, arms, and palms. The Benadryl has really not helped. So she denied any cough or sore throat, no shortness of breath, really no other symptoms. Medications are here: lisinopril, rovastatin, Benadryl, the fluconazole we talked about. Okay, physical exam, fairly unremarkable until you get to the skin, but there's the blood pressure and the pulse. The lungs were clear, the abdomen was fine. If you go to their examination of the skin, revealed geographic macular lesions of both arms, palms, and the trunk. The patient was given topical hydrocortisone cream, 2.5%, to the rash 3 times a day, and increased the Benadryl to 50 milligrams 3 times a day. The patient was told to return if she got worse, otherwise to return in a week. So fairly common presentation to the dermatology practice. Unfortunately, since we're talking about it, the 3 days later, the rash got worse, got painful, a lot of sloughing occurred. The patient was taken to the emergency room, and the patient was found to have large blistering areas of epidermis with several bullae over the back, trunk, and lower extremities, and a lot of them being lynched by pressure over the sites. And she had a fever of 104 degrees. So things turned bad quickly here. She was diagnosed with Stevens-Johnson syndrome and topical epidermal necrolysis due to peeling blisters, which was confirmed by biopsy at that time. Because of the acuteness of the symptoms, she was admitted to the burn unit, but unfortunately died the next day. So we have a death. So the PCP, the dermatologist, and the PA were all sued for malpractice for missing the diagnosis of Stevens-Johnson syndrome and leading to her demise. So the plaintiff's attorneys opined that the cause of the condition was likely the fluconazole that was given by the primary care provider a week or 2 earlier. A medication, according to them, should have been discontinued by the PCP, but certainly by the physician and the PA in the dermatology practice. So that was the basis of the case. So when reviewing the medical records of the dermatology practice, it was noted that a medication list was not present in the medical chart. The PA does describe asking the patient about her medication history, and the PA testified that he saw the patient alongside the physician, although the notes were created and posted solely by the PA. So the real question here, and granted, it's a very short description of the case. In these cases, if you get the case, it's binders and binders of testimony, but you sort of get the gist of the issue. So, and the question in this case is, did the PA have a duty to care? Obviously, yes, that was referred there. The real question is, did the PA breach that duty? So, and how do we find that out? During discovery, expert witnesses are hired to come in, both for the plaintiff and for the defendant, and talking about whether the PA met standard of care or didn't. So based on what we've talked about, how many of you think that the PA breached the standard of care here? Anybody? A couple of you? How many feel that they didn't breach the standard of care? A few of you. How many have no clue? There you go, that's fine. Okay. And if you feel that the PA breached the standard of care, then you have to ask the question, did that breach of the standard of care lead to ultimately the death of this patient? And that, if this goes to trial, then that's what the jury is going to decide, okay? So real quickly here, the issue was that they missed, the diagnosis that led to the patient's death, and if they had removed the fluconazole medication, that might have saved her life. So, all righty. Well, so the question is really, what happened? So after years of discovery, if you've ever been involved in malpractice cases, you know that it takes years and years for malpractice cases to sort of move through the system, through the discovery phase. So in this case, the case went to trial, a trial verdict, which is actually fairly rare. Most cases get settled prior to getting to trial. But in this case, the trial verdict, and it closed without indemnity payment. What this means that the court did not find the PA negligent in this. So now what I don't know is what happened to the primary care physician. But what I can tell you is that in this case, the PA was found not liable for the death of the patient. Okay? So you sort of get the gist of how that works. We'll go to the second case. This is a 51-year-old male presented to the family medicine clinic for a follow-up on an injury a week earlier. He was working in the garage, the patient was, and moving some boxes when a sheet of glass fell on the dorsum of his foot, causing a 5-inch laceration. He was taken to the local emergency department by his daughter. The ER doc examined, cleaned, and explored the wound, noted the tendons to be intact, sutured were applied, and the patient was told to follow up with his PCP in 4 to 6 days. If you work in the ER, you see lots of these. So the PA saw the patient and PA saw the patient and found in the family medicine clinic where he is a known patient. Vital signs are there, were normal. The patient takes 1 baby aspirin a day. She's been taking Tylenol 3 times a day for some discomfort. Patient complained of a small amount of discomfort and some redness around the wound. Patient examined the foot and the PA examined the foot and was able to get the movement of all toes, although a couple of the toes had minimal movement due to the pain, and all pulses were intact. The kind of exam that he would hope everybody would do when they came to follow up for this kind of an injury. So examination of the wound showed minimal tenderness and erythema. Patient did not have diabetes. As a precautionary measure, and after determining the patient was not allergic to any medications, the PA did prescribe some cephalexin every 12 hours for 10 days just to cover the patient, and a follow-up appointment and suture removal was suggested for 5 to 7 days. Pretty common follow-up. 3 days later, as the pain in the foot got worse, the patient was seen by a local podiatrist who noted an increase in redness and pain surrounding the wound. The patient was really anxious, and the podiatrist ordered an MRI, which showed tendon damage of the 3rd, 4th, and 5th tendons. Okay, so orthopedic surgeon was called, and the patient took the patient's surgery to repair what he called shredded tendons. The patient did not do well post-surgery, and with a continuation of pain and numbness and mobility limitations. 6 months later, he still had pain and numbness, was placed on Wellbutrin, then increased 3 days after that on gabapentin, and like that. So due to his lack of mobility, the patient could not perform his vocation as a male person and continued to have numbness and immobility. The ER doc and the PA were sued for malpractice. Remember, the doc in the ER was the one that sutured up the wound. The PA was in the family practice that did follow up to this case. They were sued for missing a diagnosis of tendon lacerations. The plaintiff's expert opined that the tendons were not adequately visualized by the ER doc and should have been referred urgently to an orthopedic surgeon. They also testified that the PA, in follow-up, should have immediately referred the patient to an orthopedist. Okay, so all medical records were reviewed, again, during discovery phase. The ER doc testified that he had examined and explored the wound carefully and did not see any tendon damage. The PA also testified that she was able to get movement in all toes, albeit some were a bit sluggish. PA was an excellent witness and a very experienced PA in the community. She explained clearly that her care and treatment of the patient, seeing no reason for an urgent referral to an orthopedist. So again, so the first thing is, did the PA have a duty to care for the patient? Absolutely. Second question, did the PA, breach that care? So by not sending the patient to an orthopedic surgery during the follow-up of that tendon laceration repair. So how many people think that the PA breached that care? I don't see any hands. How many people feel that the PA met the standard of care in this case? So a lot more people, okay? And since nobody thought that the PA breached the care, then we're looking at the proximate cause. Okay, so what happened? In this case, the PA was dropped from the case. And that's a fortunate thing. Unfortunately, the physician who was also sued settled out of court, which happens very frequently. But in this case, after a couple of years of discovery, having expert witnesses, the PA was dropped from the case. Now that's good, but if you've ever been sued, it's not a great experience, even if you settle, out of court. Okay, so let's talk really quick about liability insurance. There are really two kinds of insurance. There's what's called occurrence-based and claims-made. And the best way to explain that is occurrence-based insurance, which is usually recommended, is something that if you start today and you work for a company for 5 years and then you leave, and something occurred during that 5 years, a malpractice case is filed during that 5 years, even though you're gone, with occurrence-based insurance, it will cover you. If you have claims made, it only covers you during that 5-year period of time, if that's the time that you worked. And if you leave and then you're sued, then you need to have what's called tail coverage, which is relatively expensive as well. So when you're looking for, the kind of insurance that you want, you need to determine whether you want occurrence-based or claims-made. Remember, occurrence is probably a little bit more expensive. The second thing that I would say is, my opinion, is that if you're going to get some malpractice insurance, that it ought to be something that's in your name. That's that's good, because that means your name is on the document. And if you are sued, then the insurance company helps find you an attorney and works with that attorney. So rather than a lot of places now have vicarious liability in the practice. And the problem with vicarious liability, while it covers you, it also covers everybody else in the practice, and you share in the limits of that liability. So, all right, great. Time for questions, I think. Lots of people here. You should have, yes.
So you talked about tail insurance. If I purchased a malpractice insurance and just did the occurrence, and I'm staying at my job for many, many years, and I decide, all right, I'm leaving my job, should I then get tail insurance at that point so that I'm covered in case I leave?
So let me see if I understand your question. So when should you buy tail insurance is the question. And so again, if you have occurrence, then you don't need tail insurance. And well, if you can help me out with questions, but if you have claims made, then that's when you need to have tail insurance that'll cover the time from the time you left that practice on. So, was that right?
Greg, do you want to repeat the question for everybody?
Sorry.
It's not your trouble.
Good morning. Thank you. Great talk. My question was, when would be the appropriate time to get tail insurance? Typically, personally, I have my own malpractice and I have an occurrence policy, but I don't have tail. So when is the best time to get tail insurance? Is how you understood my question was. So I just
yes.
That was the question.
Yeah, my understanding is if you have occurrence, you don't need tail. If you have claims made that would only cover the period of time, then you need to get tail. And the best time to get that, is just before you leave that practice to cover you further on. Make sense?
Yeah, so you're all set. And occurrence will be more costly on the front end because it's a flat cost going forward. Claims made will start usually around 20 to 30% of the occurrence rate, and then it steps up every year. And then when you buy tail, it's usually like 200% cost to cover all of the years prior. So that's what Randy means by it could be a little bit costly at the front end, but the tail could really come in, and you're starting to move on with your life, and now you got this massive liability if you don't buy it, and a higher cost.
Over here.
How long would you need tail insurance? Like, is there a statute of limitations on suing fees?
It's the statute of limitations depends on every state based on care, based on age and maturity of the patient, right? So it all depends. If you're a pediatric population until their age of competency, plus 2-3 years on top of that, right? The tail will vary depending on the insurance company you work with. Some will only do it for a year. They'll kind of lower the cost. Some will do 2, 3, 5 years. Some do unlimited. We do unlimited for ours, so it does vary. Like Randy was mentioning, a lot of these cases go through the process, it takes years to do it. You could be getting these claims, as you have full practice authority, you're opening up a practice now, you have something from 5-7 years ago. So it is something, I would look for an indefinite or unlimited tail. Does that make sense?
Yeah, absolutely. I was talking yesterday with a colleague who was an expert witness in a case where the same attorney in the case was the attorney for the clinic and the physician and the PA. And it turns out that it was a surgical complication. Turns out that the physician was in error, and to clear the PA, had the same physician, the same attorney, to clear the PA had to be shown that there was no liability going on, even though the physician, had made an error. The point I'm making is, that gets kind of hairy if you have the same attorney, taking care of the clinic and the physician and the PA, which is why having your own insurance, gives you an opportunity to have your own attorney to take care of your needs.
This is similar to claims about tail insurance, but for people that are leaving clinical practice, either through retirement or entering a non-clinical position, what's your recommendation as far as tail coverage for those individuals that are currently clinical practice?
Yeah, you still need it. It occurred something happened here, and depending on the statute of limitations, as Will said, you're still going to need that, even though you're no longer practicing.
Yeah, and it's usually they only give you a window to do it. So you usually get 30, 60 days max with most companies. Once you're done practicing and your coverage is expired or terminated. So you can't wait. Like Randy's saying, if you know you're going to leave a company and you're moving on with your life, you want to immediately talk to that malpractice carrier and say, hey, I'm doing this in 45 days. Get the price up front, figure out, because the cost can be a big amount. And sometimes you can negotiate that with the employer, or they'll say, hey, we cover that for you too. So there's other iterations of it. And then you kind of move on with it. But the liability and incidence doesn't change just because you start doing medical writing and teaching, right? Still an instance of cost.
There's a really great resource out there. It's called medmalreviewer.com. I don't know if people are familiar with it, but it takes you through different lawsuits and testimony and all that. You can read that as a provider. But the theme that I see when I receive these, they come out like about once a month, and it seems like the amount is always far superior than what people have. I think most people have like a 1-3 million policy, and so I'm just wondering, like, when someone sues for a crazy amount, 10 million, 15 million, then clearly the PA is not going to make that much money in their career. Who pays that, and how does that work? That's kind of probably very intimidating for most of us, but I always wondered about that.
Yeah, great question. And I think we all know the answer to that. And that is, that you buy a policy and you determine the amounts, based on whichever you choose, and when if you're sued and you were found guilty for limits above that, you're responsible for that. And now the good thing is usually you're not the only one sued. So other people will share, in what the limits are. But usually if it goes above the limit and you're found guilty by a jury, you're responsible for that.
Yeah, so that's why we always kind of teach people, listen, like, we live in America, you're personally liable for what you do. Whether you work for a company or not, what's that? I think so. One of the things, from an external point of view, doing the insurance realm, is what Randy's talking about is like a supervision route. If you drop that doc off of those cases, okay, maybe you're not liable, but you could be spending now years of your life in anguish about what's going on in my life. Am I going to get sued for $500,000, $2 million? you're going to be a primary target, or at least higher so, right? So you might not pay out the liability, but the cost of defending is a big aspect of what you need to know. Most, if you want a good insurance policy, you want to make sure the defense is outside your liability. Because you could pay $2 million for a claim. Pay $1 million for liability, $1 million to defend. And some policies just say we only cover the liability and defense up to a limit of $1 million. And now you're done. And you're on the hook for that. So that's you're personally liable with your own assets that go just like anything else in the country.
Yeah, and that's a very good question. And the answer to your question, what's going to happen as the states start taking away supervision requirements? We don't know. Time will tell on that. However, what we do know is that PAs are held to a standard of care, just like physicians are, and expert witnesses determine that. That's not going to change. So, as long as PAs continue to keep, quality care, that scope of practice will be determined. So time will tell, but I think we're in a good position just because there are many studies, as you know, out there that look at the quality of care compared to other providers.
Yeah, but what I would say is you need to be thinking about this before you get to that point. Yeah, you don't want to understand how to run a business and what the risks are related to that right after you get full practice and you're looking at opening up something. We'll be looking at, do you have a business model that's commercially viable? What can I get sued for? Okay, I'm going to do these type of procedures. What's the risk of that? Or I could use lesser risk ones and kind of have more recurring revenue. But that's the same as you look for your risks too, for lawsuits.
Other questions? We've got time for one or two more.
Thanks. I work for a hospital, and I have a $1.3 million lawsuit for claims for occurrences and claims. Do you have insight into whether providers who have that type of insurance will get additional insurance, or do you see that most providers who fall under that category are okay? It's sort of murky to tack on additional insurance, or whether you're fine with a hospital who gives that sort of coverage.
So I'm trying to understand the question. So is the hospital providing the insurance, or you're providing it?
The hospital provides $1 million in occurrences, $3 million in.
Gotcha. So you're asking, should you buy some of your own on top of that?
Right, exactly. Yeah, practicing emergency medicine.
Yeah. Well, first of all, and Will, you can jump in on this, but first of all, I would take a look at that policy to be clear, where you stand in that policy, whether it's vicarious liability that the hospital is going to cover you and a bunch of other folks, which means you share in the limits.
That's right. It's for each provider, they have that occurrence, but it's under a policy.
Right. So if I understand that correctly, you're going to share in that 1 million, 3 million. So if 2 or 3 of you get sued and the suit is successful, you're not going to share in that, and so you may be liable for anything above that. So my suggestion is to get your own insurance on top of that, so that it covers you, and the insurance carrier will cover an attorney to take care of that for you. Be interesting what other folks thought.
To follow that up, do you have any recommendations on asset protection? So if I buy a house and I can get sued for my house, should I buy that house as an LLC business and make sure that no one will sue me for my property? Do you have recommendations on that?
Great question. We could spend another 3 hours on that one. First of all, I would get a professional to give you that advice. I'm not an attorney, I'm not an accountant, but there are some great articles out there about protecting your assets. And if you have that concern, I think it's a great idea to get some advice on that.
Yeah, I think another piece that just think about that, when you're working for an employer, they don't normally cover licensed defense. So hospital might cover you jointly with everybody else as they sue from a liability perspective, but if this is a license issue, they might say you're on your own. The frequency that you see with a lot of folks like NPs, PAs, nurses is usually on frequency of license issues and disciplinary issues. Those can be, just to get an expert to defend you on that, $5,000, $10,000. Rate the lawyers. So it's something to think about. And then also, when you have your own liability policy, it's got to have your name, and it covers you with your own advocate at the same time as the hospital. They can work in conjunction as a team, but you have to be aware of at some point the risk is going to fall someplace. And as for like asset protection, I think that's where you talk to a financial advisor. They can advise you on, hey, we got an attorney in town, you got to set up your estate planning. Maybe you should put your home in trust, you know, your 529s, all that type of stuff that Randy could spend 3 hours talking about. So it's a lot of information to consider.
Yeah, another question that always comes up is, why should I get my own insurance to have these limits? Because, you know, then I have money in my pocket that people can come after. You know, that's, I think that's sort of a weak argument. I would much rather, you know, make sure that I'm covered, you know, for anything that comes up. Other questions? Last question. Well, it's been wonderful. Thank you guys for spending a few minutes with us.